Okay. Good evening, everyone. I'm Dr. Sajeevan. I'm the head of the department at Medical Oncology at MVR Cancer Center, Calicut, Kerala. And my colleague is there, so Dr. Sujay also. And today we have our candidate from Amrita Institute. She'll be introducing herself. And Sujay, you just introduce yourself also.
Yeah, hi everyone. I'm Dr. Sujay. I've recently shifted to Kerala from Mumbai. Prior to this, I was at TMH as a faculty over there in medical oncology. Right now, I have started the medical oncology department here at Bharat Hospital in Kottayam. I'm glad to be here. This is my first time I'm conducting a case discussion on this platform here.
And Doctor, just for check. And yeah, Ranju.
Yes, sir.
Yeah,
Sir,
am
I audible?
Yeah.
Myself, Dr. Anju Farsana. Sir, I am doing final DM in Amrita Institute, sir.
Okay. Final year. Okay.
Final year.
So you'll be. Okay. When you will be giving the exam?
2025 April, sir.
Okay. I think without wasting much time now, we are right at the correct time. So I think you can proceed, Dr. Anshu.
Okay, sir.
Recording in progress.
I'm proceeding to the case. 23-year-old male, MBBS student from Kottayam. He noticed left scrotal swelling of 2 weeks duration. History of presenting a complaints. He was apparently normal 2 weeks back when he incidentally noticed swelling left side of the scrotum. The swelling was insidious in onset and was progressively increasing in size to attain the present size. It was not associated with pain. There was no history of any scrotal trauma. There was no history of any fever or redness on the skin over the scrotum. No history of any change in swelling, size of the swelling on coughing or straining. There was no history of cough, hemoptysis or breathlessness. There is no history of any lump or pain in abdomen. No history of any loss of weight or appetite noted. No history of any headache, vomiting or seizure. Coming to the past history, there was no history of any previous scrotal or pelvic surgeries, no history of previous hospitalization, no known comorbidities. Personal history is unmarried, not a smoker or alcoholic. He follows mixed diet. Family history, no significant history of malignancy in the family. So that is the end of my history, sir.
Okay, Dr. Anju, can you summarize your case after the end of this history taking?
So 23-year-old MBBS student noticed left scrotal swelling of 2 weeks duration, which is gradually increasing in size over the 2 weeks. It was not associated with pain. There is no history of any trauma or fever.
Okay. Would you like to add something while introducing the patient? Like you said, 23-year-old male. After that, would you like to add something just to summarize at the end?
No known comorbidities, no significant family history.
No, exactly. I wasn't asking about that. So what is your differential at this point of time?
Sir, considering the age and the increase in size of the swelling over the 2 weeks with negative history of any trauma or fever, my first DD would be a testicular malignancy. The next DD will be benign causes.
Like
hydrocele, varicocele, epididymoorchitis.
Okay. So what I wanted actually from you is like if you're keeping a testicular cancer as a differential, while summarizing, you should also be talking about the marital status and whether it is completed or not. Why is that important? I mean, in your summary for this particular case, if your differential at the top is a testicular malignancy, you should be also telling this 2 points, whether he's married or not, and whether the family is complete or not. Why am I saying this?
testicular malignancy is closely associated with infertility, and also if we are planning for treatment, the patient would require a sperm banking prior to the start of the treatment.
Yeah, exactly. Can you go back to your negative history?
No history of scrotal trauma,
Hmm.
no history of any fever or redness on the skin over the swelling,
Why did you ask this?
to rule out epididymo orchitis or epididymo orchitis
I have some work.
or any infective etiology.
Okay.
There was no change in size of the swelling on coughing or straining.
Okay.
No
Why
history
this? Why this particular history?
of to rule out hernia.
Okay. And also you can add whether the change in size occurs with any change in the, the position of the patient, like while lying down. Or
No, okay, sir.
then
No history of any cough, hemoptysis, or breathlessness.
why?
To rule out lung mets or an advanced disease.
Before that, before you come to lung mets, would you like to ask some other, which you are kept lower down, but and also to some degree in a greater extent, you will have to have that history. Where would the mets from a testicular cancer go first to?
Inguinal nodes.
Oh, that's
Lung mets, sir. Sorry, sir. Lung mets.
yeah, sure. Lung mets.
Is it?
What?
I video call Varsha. കാണിച്ചായിരുന്നു വർഷം.
First nodal station is para-aortic node, sir. Are you telling about the
What-
metastasis or
What
para-aortic
is-
node?
So you are
Para-aortic node.
you are ruled out. You are
Vera.
mentioned about some pain in the abdomen. Is it common pain in the abdomen or some other pain?
Dragging type of pain associated with
Where else the pain? Where else the
back. If there is large para-aortic node, there can be back pain.
okay.
Right. So when you are asking about history of metastasis, like first you are looking at negative history to rule out someone's mic is on.
Please, others, please mute the mic. Those who are not actually. Somebody can put it in the chat, I think. Okay. Okay, Anju, carry on.
So Anju, when you are asking about the initial few histories, it is regarding to the differentials at the testicular level, right? After that, you are going to ask about metastatic history, then you would preferably be asking in terms of the sequence in which the mets are going to happen. So the first echelon of lymph nodes that will be involved is what
Para-aortic.
for a testicular lymph node, for a testicular cancer.
Para-aortic node.
Okay, is there any difference for the right testicular
Yeah.
lump versus left in terms of RP lymph nodes?
First, right sided testicular malignancy, first drainage site will be inter-aortocaval para-caval, then they'll be draining to para-aortic node.
Okay.
Left will be first going to pre-aortic, para-aortic, from there to aortocaval, inter-aortocaval node.
Okay, good. And is there also any sequence in direction, like right to left or left to right? Like if the lymph nodes are involved, usually in what direction are they involved? It's
Right
usually
side,
right to left.
right to left.
Okay, so in terms of your history for the RP lymph nodes, your negative history is insufficient. You would have to ask, other than the lump in abdomen and pain, you would have to ask about back pain. Okay, the lumbar type of a back pain. And also if there are RP lymph nodes higher up, like retroduodenal and all, what would the patient have symptoms of?
Sir, about retroperitoneal nodes or?
Yeah, in other words, from the retroperitoneal node, what is the next level of metastasis? What is the drainage of this?
Pelvic nodes.
Pelvic, are you sure? When will the pelvic lymph nodes come into the picture?
When skin of the scrotal skin is involved, pelvic and inguinal nodes maybe.
Okay, if there is a scrotal violation, the
Mm.
inguinal or the pelvic lymph nodes may be involved. Let's say this patient does not have a scrotal violation, right?
Yes, sir. Yes, sir.
If a scrotal violation is not there, but I say that the inguinal and the pelvic lymph nodes may be involved, how would that happen?
कोई नहीं और मामा जब वो बनाते हो ना मशरूम या तो मशरूम बनाती हो
Even
या
before
अंडा
a
बना देते हो
scrotal
मिक्स करके वो बड़ा गंदा
violation, the tumor itself invade skin of the scrotum. There can be inguinal nodal metastasis.
That's a different scenario we are talking about.
PT4 disease.
See, what is the reason for pelvic lymph node involvement? So, see, you said about para-aortic involvement. From there, what happens next? Or in other words, what is the normal distribution of these lymphatics? From the pre-aortic, para-aortic, retrocaval, whatever it is, then where is the next level, next station?
Sir,
So it goes to the retrocrural group of lymph nodes. From there, it will go to the mediastinum.
mediastinal nodes. Okay, sir.
Which mediastinum? Anterior,
Anterior
posterior?
mediastinum.
Anterior mediastinum. Why?
Right. So it is like RP. Then through the chylus tract, it would go up. Okay, retroduodenal, then to the mediastinum and also to the neck, right?
Yes, sir.
Supraclavicular lymph nodes can be involved. So you do have to ask about history of lump in the neck also. And when I was asking about higher up symptoms, you would have this GO symptoms, anorexia, nausea, vomiting. Those can happen if there are lymph nodes which are retroduodenal. So to answer the question that without scrotal violation, when will pelvic or be involved? When these RP lymph nodes are bulky in size and there is a blockage in the lymph drainage, then the spread will come down to the inguinal and the iliac group of lymph nodes. Okay. And also if any history of prior pelvic surgeries.
Yes, sir.
Right.
Then also the drainage will.
Yeah, when the drainage gets blocked, then the lymph
blocked.
nodes that will be involved are the lower down.
Yes.
One another history that you have not asked is about the bone metastasis.
Bony pain.
Okay.
Okay, sir.
Yeah. So come to the next slide on the history. Why did you ask for this surgeries of prior scrotal pelvic surgeries? What kind of pelvic surgeries are you wanting to ask in this particular case?
Previous history of any cryptorchidism or any surgeries for that?
Yeah, specifically you want to ask whether the patient has undergone an orchiopexy for cryptorchidism, right?
Just I want to interpret. Dr. Anju, you put on this your video. That will make communication more better.
One second.
You don't mind, no problem.
Oh, okay. Sir, one second.
Okay.
And one more, why the family history?
There is risk for germ cell tumor if there is a strong family history. If the father has a testicular malignancy, there is 2 to 4 fold more risk for developing testicular malignancy. If the sibling has testicular malignancy, he has 8 to 12-fold increase in risk for germ cell tumor.
Yes, correct. So if the brother has a malignancy, testicular cancer, the relative risk is higher when compared to that of the patient's father having the malignancy. Correct. So after this, when you summarize the case, you will have to give a differential also, right? Would you like to summarize again after all this discussion? Anju?
Anju, you put on your video.
Anju, your mic is mute.
Video.
It's okay. If you are not finding it easy, it's okay. At least start talking.
Anju, can you hear us?
Yes, 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 sir. Yes, sir.
Now, can you please summarize once again after all this inputs that we gave for your case on the basis of your history and exam, on the basis of history taking?
23-year-old male, unmarried, with no comorbidities, no significant family history,
Yes.
presented with left testicular swelling of 2 weeks duration, which is gradually increasing in size, with no evidence, with no history suggestive of trauma or infection, or no history suggestive of advanced disease.
Probable differentials? Before you say advanced disease, you will have to give differentials, right?
Differentials in this term is, sir, probably malignant neoplasm, testicular malignancy. Second DD will be benign causes. Testicular malignancy, it can be germ cell tumor. It can be malignancy arising from paratesticular structures. It can be a metastasis to testis.
At this age, which is the commonest?
Germ cell tumor.
Germ cell tumor.
Non-seminomatous germ cell tumor.
Why do you say non-seminomatous?
Age 23 years.
Yeah. So in short, in which decades are seminoma and non-seminoma common?
Seminoma common in 20 to 45. Non-seminoma usually seen at 15 to 30 years of age.
So there is an overlap. So if I say
but not the same.
dash decade,
So which one comes in the later decade?
Seminoma.
Okay, which decade you will be talking about? Normally, seminomas are usually is common in 20s, 30s, 40s. Which one you will select?
30s.
30s or 40s?
okay, 30s. That would be the fourth decade. Okay.
Right.
Yeah. Have you heard of that?
Prepubertal germ cell. Yes, sir. GCNI is usually.
Correct. Very good.
What is the terminology for pre-malignant condition of germ cell tumor?
Germ cell neoplasm in situ. GCNIS.
Okay, right. Okay.
So
What
maybe
is the, sorry. What are the other common testicular neoplasms happening in the younger age group, like 10, first or second decade?
Younger age,
They're not common.
pediatric age group, we can find RMS.
Okay, then
in 15 years and old, usually teratoma, yolk sac tumor,
then
commonly seen.
Then uncommon. Same age group, uncommon.
15 years.
What are the
there is a
interstitial
sex,
cells there?
there is a sex cord
stromal tumor.
stromal tumor which has two peaks of incidence, one in the very young age and one later. Which is that tumor?
Granulosa.
Not exactly. What are Sertoli and Leydig cell tumors? Okay.
They are sex cord stromal tumors.
Okay. Most of them are benign or malignant? By and large,
malignant. Sex cord stromal tumors are
always malignant. What are the characteristics of sex cord stromal tumors? Characteristics of sex called stromal tumors.
2 each peaks will be there usually.
That's already told. Apart from that, will you get any hormonal dysfunction or hyperfunction or any manifestations out of that, or with all these things? Isn't it? Will you get? You tend to get, no?
Yes, sir.
Yeah, there may be hyperfunctioning, thereby they may produce gynecomastia or precocious, or the otherwise precocious puberty may be there, isn't it? Most of them may not be malignant also. Right. So it will be malignant variety as well as benign variety will be there.
Both benign and malignant variety.
Okay. You told anyway, one more I will add on to that. You talked about granulosa cell tumor. Which age group it will be common? Granulosa cell tumor of the testis.
Twin.
No. If you
20s.
read the textbook, you can find that it is malignancy of infancy also. It can rarely happen in infancy. Okay.
Juvenile age group.
Okay, forget about not even juvenile infancy. Okay, right. Go on. Okay, Sujay.
Yeah, we'll go to the physical examination.
So patient is moderately built and nourished. There is no dysmorphic features from head to toe examination. Normal voice, there is no gynecomastia. ECOG performance status of 1. There is no pallor, cyanosis, clubbing, pedal edema, or any generalized lymphadenopathy. BP of 120/80 millimeter mercury, pulse rate of about 72 per minute, respiratory rate normal, height of 171 centimeter, weight 69 kg, BSA of 1.8 meter square. Local examination of external.
Wait. We'll elaborate something on general examination, right? Okay. So what is the implication of normal voice?
Sir, Klinefelter syndrome.
Yeah.
I want to rule out.
So can you just highlight a few points on Klinefelter syndrome randomly? But how will be the morphology, dysmorphic features you told? Klinefelter syndrome fellows, how will they will be looking?
So patient will be tall in nature. There will be female type pubic hair. There will be testicular atrophy.
Gynecomastia, right?
Gynecomastia, yes.
Okay. So normal voice, okay, normal voice, right? And any other syndromes you can think about? You told about dysmorphic features. So what are the other syndromes you are having in your mind when you're dealing with the testicular cancer?
Tumor dysgenesis syndrome. Then
Tumor dysgenesis syndrome.
Down syndrome.
Down syndrome. Okay. Any other syndrome associated with the testicular? Noonan. Then so okay, rarely you can have Puget syndrome and all. Okay. And anything else?
Usually Klinefelter's Down syndrome.
Okay, carry on.
One question here. What is the significance of pulse in this case? Can there be a tachycardia in a germ cell tumor, and why would that be? What is the significance of pulse and BP here?
The patient can have tachycardia if the patient tachycardia and tachypnea if the patient has some respiratory lung metastasis or mediastinal mass producing.
No.
I'm asking about a paraneoplastic phenomenon, endocrinopathy, which can cause tachycardia. I've given you a clue. Paraneoplastic endocrinopathy.
Associated with the testicular cancer.
Cushing syndrome.
Okay.
It's
Okay, we'll
hyper.
come to that. We'll come to that when we'll talk about the investigations. For time being, we'll keep that aside, right, Sujay?
Yeah.
Yeah. Okay.
So coming to the local examination, penis appears normal, urethral orifice appears normal. There was coarse pubic hair. Inspection, right hemiscrotum appears normal. There is enlargement of left hemiscrotum. Skin over the scrotum appears normal. On inspection, there was a left-sided scrotal swelling of about 3 into 3 centimeter, which was globular swelling, which do not reduce on lying down position. There was no co-fimbres. There was no visible scars or sinuses in scrotum or inguinal area. On palpation, temperature was normal, no tenderness, right testis normal, left-sided testicular swelling of 3 into 3 centimeter, hard in consistency, smooth surface, non-tender. Testis was not separately palpable. Swelling was non-reducible, cuff impulse was absent. It was possible to get above the swelling. There was transillumination or fluctuation. Systemic examination per abdomen soft, normal, all quadrants moved equally with respiration, respiratory system, bilateral normal vesicular breath sound, CVS, S1, S2 heard, no murmurs, CNS, no focal neurological deficit. That's the end of my examination. So.
Wait, examination, you just wait. Just put your slides. What is the abnormality sometimes you can expect in external genitalia penis?
Hypospadiasis.
Okay. Okay.
Then in dysgenesis syndrome, the hair, there won't be sometimes coarse pubic hair.
Okay.
When you are examining the patient, it is always good to mention how you examined in what position and after exposing which parts, right?
Okay.
At the start itself.
Patient was
So when examining this scrotum, you will have to say in what position you had examined and by which method, right? In describing the palpation. Which method do you use for examination of the testis? Dash palpation. I'm talking
patient
about
was examined in both supine and standing position.
So when you are palpating the testis, how did you palpate?
Using bimanual technique.
Okay. Which testis did you examine first?
First I examined normal testis, then went into the swelling.
Why is that done?
To assess the testis, see any nodularity or anything present in the contralateral testis, any atrophy seen in the contralateral testis.
No, it's basically you get to know the comparison of that abnormal side is always after comparing it to the normal, right? So you get to get an idea of the size, the consistency, and the feel, and then in comparison to the normal testis, you would palpate the opposite one. There is one thing that you have not mentioned in the palpation here. Did you check for the testicular sensation?
Testicular sensation was present.
It was present.
Yes,
It's okay. It can be present in the early small lumps. Usually when a larger lump which is occupying more of the testis, then because of involvement of the afferent nerves, the sensation might be lost. But you'll have to mention that.
Okay, sir. Okay, sir.
You are able to get above the swelling.
Yes, sir.
And however, like on the basis of palpation, is there any way? It's not foolproof. However, on the basis of palpation, can you make a comparison between a seminoma and a non-seminoma? any features which are more in favor of seminoma, features which are more in favor of non-seminoma?
Don't know, sir.
Okay, more of irregular margins or an irregular lump can be non-seminoma. right?
Non-seminoma. Okay.
Can you get hydrocele or varicocele along with the testicular mass?
Can be, sir.
What are the reasons?
Due to the lymphatic obstruction, hydrocele may be present.
Hydrocele may be present. Okay, secondary
Secondary hydrocele or secondary varicocele.
hydrocele or secondary varicocele. Okay, right.
And also in palpation, you have to mention about the spermatic cord, right?
Yes, sir.
Inguinal thing is mentioned. I just forgot.
Inspection.
Okay. Is it mentioned?
No generalized lymphadenopathy I have mentioned in general examination. Scars inspection I have written about the scars and sinuses.
Right.
Separately in palpation I have not written, sir.
Okay. In the lymphadenopathy part, just mention about the supraclavicular lymph nodes too. Okay.
Okay, sir.
Just highlight that point for your case. The reasons
sir.
we have discussed earlier, right?
Okay, sir.
In just let's say hypothetically, along with the testicular lump, you get a central abdomen lump. Okay, in this patient, let's say it is there. And on palpation, how do you feel the palpatory findings would be for that central abdomen lump? Why would that come? It would come because of RP lymph nodes, right?
Retroperitoneal lymph nodes. Yes, sir.
Right?
Yes, sir.
So what palpatory findings would you be expecting in that case?
Moves with respiration.
Moves.
Retroperitoneal. No, it doesn't move with respiration. So,
How would you find out if it is retroperitoneal or arising from some organ?
You do what? Bedside test, clinical medicine. How do you find out the plane of the mass in the abdomen?
ask the patient to lean forward.
Lean forward. There are two tests or two positions you ask the patient to come to. Do you know?
Raising the leg and.
Okay. By raising the leg, what are you ruling out? Okay. Maybe you can go and read about that. How to come about the position of the lump in the central abdomen. How do you determine if it's intra-abdominal versus retroperitoneal?
Okay. Okay, sir.
Sir, any question?
It's okay. Carry on.
Yeah. So just summarize the case after your history and examination findings.
23-year-old male, unmarried, with no known comorbidities, no habits, presented with painless swelling in left side of the scrotum of 2 weeks duration, gradually increasing in size. And on clinical examination, there is a hard 3 into 3 centimeter left testicular swelling noted.
Okay. Without
any palpable inguinal or supraclavicular nodes.
Inguinal, abdominal, or supraclavicular
nodes.
Okay. And no other systems already told. Okay.
Systemic examination.
Already told.
Yes, sir. Yes, sir.
After this, you will have to give a differential also.
Yes.
You just elaborated the history and the clinical findings.
My differentials at this point, primary would be a malignancy, most probably a germ cell tumor. Other differentials include tumors arising from paratesticular structures, Then metastasis to testis. Age is not
Yeah, that's fine. You can, if asked for the other differentials, just have few of them in your mind, okay? So how would you now proceed to investigate this case?
I would I would get an ultrasound scrotum for this patient. Along with that, tumor markers including beta HCG, AFP, and LDH. Then all baseline investigations including complete blood count, renal function, and liver function tests, sir.
What are you do ultrasound? What are the features of testicular malignancy in ultrasound?
Usually hypoechoic mass with internal vascularity.
Okay.
And there will be microlithiasis, usually.
Microlithiasis.
Yes, sir.
Where will you see microlithiasis? In testicular malignancy or?
GCN, it is usually associated with
Okay.
GCN. If there are 5 or more echogenic foci of 1 to 3 mm in single cross-sectional field, it is highly suggestive of malignancy.
That is, we are talking about testicular microlithiasis, isn't it?
Yes, sir.
Here we are dealing with a mass per se, right?
Yes, sir.
So you need a ultrasound with a
Ultrasound.
Doppler added on it. So it's always a Doppler with the ultrasound. You will be checking for the vascularity. You will be checking for the pattern, heteroechoic, hypoechoic lesions, right?
Yes, sir. Then size of the swelling.
Yeah.
Then contralateral testis also.
Yes. There you can mention all these microlithiasis and all those things. If you want, you can mention there, right? Then, so ultrasound will tell you about the possibility of germ cell tumor, right? What will be the ultrasound findings in other these things? Like, for example, if I'm saying that it's a lymphoma, malignancy with a testicular involvement, right? Can it be?
Yes, sir. It will be well-defined, homogeneous.
Okay. What is the normal level of beta HCG?
24 to 36
No,
hours.
no,
Sir.
level.
Level is less than 1 nanogram per
Are you
ml.
sure?
Beta HCG. Beta HCG's level is less than 1 nanogram.
Other unit is international units per ml or nanogram per ml. That is all. Okay.
What is the AFP level and which unit?
AFP is usually 10 less than 10 nanogram per ml, sir.
Is it in nanogram or some other unit?
Usually 10 nanogram.
What is the unit of LDH?
LDH is in the 120 to 240 international units per ml.
Okay. Okay. Right. Of this, which one is having highest half-life?
Half-life. AFP usually has about 7 days, 5 to 7 days. Yes. AFP has the longest half-life. LDH is variable.
Why you are checking only beta HCG? Why not just HCG?
Beta subunit is usually weighted in subsectors.
And alpha HCGs? Alpha part is?
Alpha part is
check HCG.
HCG.
What would happen?
is more beta HCG is more measurable.
No,
No.
the reason. That's not the reason.
Something normal in the body will have.
So what is common for alpha? Alpha is common for what?
Some other normal hormones in the body.
It is alpha subunit of beta HCG usually mimics TSH, LH, and also false
Ah.
positivity.
Pituitary
False,
hormone.
false positivity. Alpha subunit is shared with other hormones as well, right? TSH and all those things. So what will happen if very high beta is CG is there? What will happen? What are the patients present complaints?
High, because of this alpha subunit mimicking with the gynecomastia and all.
Okay, hyperthyroidism. So there is the importance of pulse. Dr. Sujay was asking about pulse, right?
Okay. Sir.
And what are the other symptom of the patient? Patient may present like
With metastasis, lung metastasis and brain metastasis features of
symptom. What symptom?
The patient will be having respiratory distress.
That is different symptom. Any other
Cough,
symptom?
breathlessness.
Okay, the hypertensive gravidarum sort of symptoms could be there because of a very high level of beta HCG. Okay. So, okay. Now we talk about AFP.
Yes, sir. Normal limit is less than 10 nanogram per ml. Half-life is around 5 to 7 days. It is also elevated in other conditions like hepatocellular carcinoma, some gastric malignancy.
Then
It it is usually elevated in yolk sac tumor and embryonal tumors. AFP is never elevated in seminoma.
Okay. AFP is never elevated in seminoma. The rest, the other two hormones, can they be elevated?
Yes, sir. HCG, about 15% of seminoma patients can have elevated HCG.
Yeah, correct. So if say the patient undergoes an orchidectomy, comes to you, it's a pure seminoma, would you be doing this markers? It's the histology is already pure seminoma. He has undergone a surgery about 4 weeks back. Would you want to do markers? Just now you said AFP will not be elevated. Would you still do it?
Baseline tumor markers.
No. The question is different, slightly different. We are not. The tumor marker was not done. Somebody has done a biopsy test, orchidectomy or something. Biopsy is telling pure seminoma. Okay, are you happy with that, or you want to do markers again?
I will get the markers once again done.
Why?
For prognostication, in case.
No. Any diagnostification? Forget about prognostification. Anything about diagnosis? Histopathologist has told that pathologist has
some mixed component element I want to rule out.
So basically the question is pure seminoma, and then if the patient comes to you, still you would like to do the tumor markers. Why? Because if the AFP is elevated to any degree with a pure seminoma, how would you treat the patient as?
I will treat the patient as a mixed germ cell tumor.
Non-seminoma, yeah.
No.
That is the importance. And other important marker is LDH, right?
LDH.
What is the implication of LDH?
Tumor. It is helps to know the tumor burden.
Okay. Tumor burden. Okay.
burden,
Okay.
proliferation rate, tumor burden.
Okay. Right. What?
When do you do these tumor markers?
Usually done after baseline will be done. After surgery, usually after 3 weeks, we will get the tumor markers done.
3 weeks.
Minimum corresponding to a half-life of 5 half-lives of the tumor markers.
Corresponding to a half-life of 5, 3, 4.
5,
3,
5,
4, 5. Which one will choose?
5.
Okay, correct. 5 T halves. So that would be how many weeks? Considering that the longest T half is for AFP.
Then it will be around 35,
So somewhere around 4 weeks.
4 weeks.
An appropriate answer would be a minimum of 4 weeks.
4 weeks.
5 T half lives. What help does it give at doing at the baseline? These tumor markers doing at the baseline. So you just said you would do it after surgery 4 weeks or 5 weeks after surgery.
Baseline markers will help in the diagnosis of
Okay. And there is one situation where
even without biopsy, even with the patient is symptomatic, even without a biopsy with the tumor markers, we can start on treatment.
Which tumor marker, preferably?
HCG.
HCG. Above what level?
Above 50,000 and
What is visceral crisis in germ cell tumor?
respiratory distress.
Then
Seizures.
okay, when
vomiting.
there is a very high tumor burden, patient may be having multi-system involvement. Okay, very high involvement with the lung metastasis, liver metastasis. Your tumor marker is very high. You won't be depending on your diagnosis. You may not be fit for a orchidectomy, right?
Yes,
so you may be able to treat the patient based on these markers alone. Okay. Okay. So there is a visceral crisis as well. You said about something. I'll come back to this beta HCG. You said some amount of pure seminomas can also have beta HCG elevation. What is the reason? Do you know? So what is the source of this beta HCG in testicular cancer? Which type of cells produce this? It's basic, okay? What sort of trophoblasts?
Syncytial trophoblasts.
There will be presence of syncytial trophoblasts. 10% of these persons can have presence of syncytial trophoblasts, which may be accountable releasing this beta HCG. Okay, fine. Right, go on.
So you did the ultrasound, you did the tumor markers. Okay. And on the basis of this, it seems to be a testicular cancer, a germ cell tumor, considering the age and all. And also, what were the tumor markers here?
This for this patient.
Yeah.
HCG was 5,500. LDH was 600.
Okay. Okay. Next, what did you do? What would you do?
We will do a CCT abdomen, pelvis, and HRCT of thorax also to complete the staging workup.
Okay. Would someone ask you whether you would do a CT or a FDG PET?
FDG PET is not recommended in testicular cancer as part of staging workup. Usually only for seminoma, after evaluation of post-chemotherapy residual disease, only we usually ask for PET CT. Workup.
Okay, fine. So yeah, the answer is FDG PET doesn't help over the contrast and CT. So your choice of staging is CT. What is the issue because of which it is not useful is that the negative predictive value is poor. So you won't get any better idea over the CT. Now, in this situation, consider that the patient is unmarried, he's young. And before you go on to the management, there is anything that you would like to do with the patient?
Sperm preservation, sir.
Yeah.
No,
See,
before further preservation. Sorry, before sperm preservation, you have to analyze the sperm, isn't
Sperm
it?
analysis and
We always
sperm
tell sperm analysis followed by sperm preservation.
preservation.
Why?
why is that?
Because even baseline itself, some patients will be having azoospermia or oligospermia. So better to get the baseline semen analysis done before the start of.
Yeah, true. When do you want to ideally do that?
Ideally before orchidectomy, but most probably patients will come after orchidectomy. So before the start of the treatment, we will be advising to get the
At least minimum before chemotherapy.
before
But
chemotherapy.
ideally
Before
before orchidectomy.
orchidectomy.
And even sometimes some say that even before the CT scan is done, for the staging purpose, you should do it. But ideally before an orchidectomy. Why ideally before an orchidectomy?
Ideally before orchidectomy, because sir, we are removing one testis, so contralateral testis, if
once you do an orchidectomy, there might be some degree of dysfunction in the spermatogenesis and all that. And also, the volume of the semen that you can get would be higher. That's the only reason, right?
Okay, sir.
So you did the CT scan, and what was that for this patient?
There were multiple enlarged left external iliac, left common iliac, para-aortic, iotocaval, precaval, and retrocaval nodes, with most of these nodes showing necrotic areas.
Size you haven't mentioned about this size, but you have mentioned about external iliac and common iliac and
Common iliac, multiple nodes with the.
Naturally, we'll be interested to know what is the size of these lymph nodes, iotocaval, precaval, and are they huge?
They were huge, sir.
Should know.
Why is that important? Is it of any significance?
Whether we should do RP-LND afferent or after the
based
chemotherapy.
on
Size of the node.
In short, we are all the staging. It's you would get a clinical stage, right?
If we do RP-LND afferent, we will get
no. For clinical staging, is the size of the lymph node important?
Yes, sir. Nodal staging depends upon the size of the tumor. N1 is less than 2 centimeter, N2 is 2 to 5, and N3 is more than 5 centimeter.
Okay, that's why.
Okay.
Would you get an idea on the T size from radiological imaging? You said about N1, 2, 3. Anything about the clinical T?
Clinical T is T from ultrasound is difficult, sir.
It's not just difficult, it's impossible. It's the only clinical T that you can understand is T4.
Yes, sir. When there is gross scrotal invasion, scrotal involvement. T3 and T4 may be picked up by ultrasound.
T3. What is T3?
Spermatic cord involvement.
That has to be pathological. Okay.
Yeah.
So after this, the patient has undergone
left high inguinal orchidectomy.
What does high inguinal mean?
through inguinal region, scrotum scar was made and scrotum was.
No,
removed.
no. You have to be very precise about what do you mean by left high inguinal orchidectomy. It doesn't make sense. Like no, high inguinal means
Where through an incision made in the inguinal.
What level or what anatomical structure? Everybody can tell no high inguinal. So somebody should probe into that. What is this high inguinal refers to actually? What exactly is there at the anatomical this thing?
They have specifically said high, not low inguinal, right? So what does that high part mean?
Please check, okay?
Okay.
Like it's like a slogan now. Everybody will tell high inguinal orchidectomy. What is this? You should think like what is there in that deep in the structure, something deep.
Okay, sir.
Right.
Now, once you do an orchidectomy, what are the factors that you would want to see in the pathological report? Just enumerate them.
Want to see the size of the lesion, the histologies associated in the tumor, the infiltration of tunica albuginea vaginalis, about the lymphovascular involvement of the
Okay.
tumor.
Lymphovascular.
Involvement, basically the what all histological components were present, the size, about the involvement of the nearby structures like spermatic cord.
Cord and involvement of the skin, all these things.
Skin.
Thereby you will be able to make the correct T stage, right?
Yes, sir.
If I say two things that you want to see in a seminoma histology and two things that you would want to see in a non-seminoma histopathology report, what two things would you look at for seminoma?
Seminoma, retitestis involvement and involvement of size of the tumor more than 4 centimeter.
Yeah.
In non-seminoma, how much the embryonal component was vascular, about vascular invasion.
LVI and embryonal
components.
On the other side, T size and retitestis involved. Okay. So what is this patient?
This patient, based upon the markers, he was intermediate grade non-seminoma.
This patient is a mixed germ cell tumor.
Mixed germ cell tumor is
dominant component of embryonal carcinoma, and there is lymphovascular, extensive lymphovascular involvement.
Yes, sir.
Okay. So now what will you do?
I will repeat the markers after 4 weeks. Then there were initially itself inoperable nodes were present. So I will start the patient on chemotherapy after sperm preservation. You will start with the PEP regimen.
No, wait. We'll go. We have time now. We'll go one by one. So okay. So what is the staging you will use? Which stage group, like that you categorize this patient?
This patient, since he has a S2 marker, the patient will patient will go into intermediate risk group.
What is intermediate risk group?
Intermediate risk group includes in non-seminomatous germ cell tumor, testis or any peritoneal primary with a marker more than AFP 1000 to 10,000, HCG 5,000 to 50,000, LDH level 1.5 to 10 times the normal.
What is this called? What the
IGCC, International Germ Cell Cancer Collaborative Group.
Risk stratification.
Risk stratification.
This risk stratification is used for which testicular cancers? I mean, germ cell tumors in which stage? All stages?
Advanced stages.
Yeah. So advanced stages what?
2A. From 2A to B.
2A, 2B
Stage,
is an advanced?
stage 2 and 3
No.
from 2B.
No. They're basically been used for metastatic, but you would that is stage 3, but you would also add stage 2C. 2C and 3 would be advanced. Okay.
Okay.
The mic. Everyone else, please mute the mic.
Okay.
Yeah. So stage 3, these are the advanced tumors, and the risk stratification is used for this. So here, after you looked at the pathology report and the radiological investigation, how would you stage this patient as? It's PT what?
It is PT1.
It's PT1.
Is vaginalis, tunica vaginalis is free, so T1.
Okay.
Oh, sorry,
then?
sir. But there was extensive LV present, so PT2.
Then N.
In initial itself,
You
patient
have
had N3. There were multiple notes.
So
Radiological
yeah.
imaging.
So it's N3. Now,
N3.
what would that make this tumor as?
N3 will come under stage 2C. Stage 2C.
Okay. Once you have staged, then what do? You look at the
Marcus, post-orchidectomy marker.
Yeah. Okay.
Which we usually done 4 weeks after orchidectomy.
I've got a message from the moderator saying the time is almost over. So,
but we haven't reached anywhere. I haven't reached the management part. So let's continue for some more time, I think, because just we have to cover all this testicular tumor. It's such an important topic. So
I think we'll take another 15. Sajivan, we'll take 15 more minutes for the management because it's a very
then
important
I'll ask,
topic. Nice discussion.
Then we'll ask.
Now go for the treatment.
We'll ask.
That's very important.
Anju, we'll ask straightforward question. You tell us about the management of stage 1 seminoma. Forget about this.
Stage 1 seminoma after inguinal orchidectomy, we have 3 options.
Okay.
Active surveillance.
Okay.
This is
list first. Active surveillance.
Active surveillance. Single adjuvant chemotherapy 1 cycle, carboplatin, AUC7. Or third option is adjuvant RT.
Okay. What is the pros and cons of surveillance?
The patient should have strict compliance, the cost associated with the imaging and the close follow-up. That is the advantages. About only 20% usually recur. So about 80% we are over treating. That can be avoided, and the toxicity associated with chemo and RT, basically second malignancy and second malignancy can be avoided with further adjuvant treatment.
Okay, what is the dose of RT used in stage 1 seminoma?
20 gray, 2 gray per fraction to para-aortic nodes alone.
Para-aortic nodes alone. Okay. Okay. What is the management of stage 1 non-seminoma stem cell tumor?
The options are, sir, RPLND, active surveillance, adjuvant chemotherapy, BEP 1 cycle.
In your institute, what you are following?
We usually give BEP 1 cycle.
Suppose you are practicing and a patient has come to you, what will you be doing? And justification for the same. Suppose one patient has come to you, NSGCT stage 1.
With high-risk features. Then we'll give 1 cycle of BEP.
Why not 2? Why not 2?
Overall survival is same with BP 1 cycle versus BP 2 cycles.
One situation where you would prefer RPLND over BEP in stage 1 NSGCT. One situation looking at the histopathology report. if that major component or
if teratoma component is high, then RPLND will be a better option.
yeah, okay.
Whereas embryonal component and extensive LVI and all, you will be giving
chemotherapy.
Okay. Right. Then stage 2 will come.
Okay. So stage 2 seminoma.
Okay.
With good risk.
Okay. What is poor risk in seminoma?
There is no poor risk, sir, only good and intermediate risk.
Okay.
So stage 2 seminoma, good risk. Like adjuvant chemotherapy, BEP into 3 cycles or EP into 4 cycles. And we will we will do a reassessment after 6 to 8 weeks. And if there is residual tumor is more than 3 centimeter, we will do a PET evaluation. And anything more than 3 centimeter, which is FDG avid, we should do a biopsy and confirm it. If resection is possible, completely resect the residual tumor. And if viable tissue was present in the resected specimen, we should go ahead with 2 more cycles of chemotherapy. If there is no viable tumor present, adjuvant follow-up is only required.
Any role of stage 2A seminoma? Is there any situation where you would not give chemotherapy? I mean, is there an option of not giving chemotherapy?
Stage 2A. If the patient has undergone hyoinguinal orchidectomy and RPLND initially, and the nodes turn to be negative, then
You're talking about seminoma. I mean,
2A.
Stage 1, you had an option of RT and chemo, right? Is there in 2A, would there be an option of RT?
RT is also an option. We will be giving a higher dose of 30 gray.
Yeah. Okay.
What are the contraindication for RT?
Single kidney, horseshoe kidney, inflammatory bowel disease.
Okay.
Yes.
Right. What is the maximum dose of bleomycin you can use?
400 international unit.
Okay.
Pre-chemo evaluation for these patients, BEP regimen?
BEP regimen, we, pulmonary function test, mainly DLCO we have to see.
And?
6-minute walking test.
Okay. Anything else? This is for what bleomycin lung toxicity that you are concerned about. Any other drug for which you want to look at something? You do the RFT also, right?
Baseline RFT to see because cisplatin is nephrotoxic, so baseline RFT must be
Right. What are the problems with the etoposide?
Risk of second malignancy, leukemia.
What are the risks according? What percentage of risk at dash dose dash doses?
2 gram per more than.
Then how much percentage of risk? After how many years?
Usually risk is more at a total when dose exceeds more than 2 gram per meter square. It is less than when it is less than 2 gram per meter square, risk is around 0.5%. If it is more than 2 gram per meter square, risk is around 2%. Usually it will be seen within 10 years after the treatment.
Or early?
Sir?
Or early? 10 years or early?
Usually within a decade, 2 to 3.
Yes. It's early. Okay.
Early, okay.
Not that what is what is the management of stage 1 is? Stage 1, yes.
One, so
How do you manage this stage 1, yes? Is there anything like stage 1, yes?
only markers will be elevated.
Yeah, what are the options? How do you treat?
Three cycles of BEP alone,
Any other option?
or 4 cycles of EP.
Any other option? Why you want to give chemotherapy always? It has been told that once chemotherapy is this, but there is an option of active surveillance even in
also,
one.
okay.
What is the reference for that? There is a meta-analysis actually. There is a newer guidelines coming up with the stage 1S also. You read your DVITA.
Yes, sir.
Okay, it is written.
Okay, sir.
Okay, 1S is not always chemotherapy. You can have an option of that.
Active surveillance.
Because, and 1S entity is actually less and less. Why? Because you have got extensive, very good imaging modalities, isn't it?
Yes, sir.
You are telling 1S when there is no documented imaging modality, image wise, you are not seeing anything in there, no? But
Yes, sir.
nowadays, all modern investigations will pick up whatever it is there. So 1S entity as such is not very common. Okay.
Yes, sir.
So there is an option also. It's a recent concept. Okay.
Okay, sir.
Then, so you want to ask something?
Poor risk NSGCT. What chemotherapy options? How many cycles?
4 cycles of BEP or 4 cycles of VIP.
What drug you have changed in VIP?
Instead of bleomycin, ifosfamide is used.
Okay. You have completed the chemotherapy. The tumor markers have normalized. You do a CT scan, and there is a retroperitoneal lymph node of 2 centimeter. What do you do now?
Since the it is non-seminomatous germ cell tumor and size is more than 1 centimeter, so we have to resect the. We have to do RPLND.
Okay, the patient is taken up for RPLND. The patient has received BEP 4 cycles. Any instructions or things that you would ask your anesthetist when the patient is undergoing a surgery?
GE will be difficult because since the patient received bleomycin. FiO2 levels and all has to be.
You have to keep the FiO2 levels low, 50 to 60, and also the central venous pressure should be on the lower side.
Okay, okay, sir.
Okay. RPLND, what type of RPLND is done? There is a term to that dissection that is done. What is that term?
Nerve sparing.
Now you classify all the RPLND. You classify the RPLND.
Modified,
types of RPLND.
Modified RPLND, nerve sparing RPLND.
So before modifying, you should be having something
radical RPLND.
Classic. Okay, classic. RPL.
Classic, modified,
Hmm.
nerve sparing.
There is more filtration there actually. You have to read precisely. Okay. What is this modified? What actually is done there? And why you want to modify?
Ejaculatory dysfunction is associated with classical retroperitoneal lymph node dissection. So to reduce the rate of
Up to what?
the incidence of
The rate is reduced up to what percentage?
Right side modified radical RPLND, right side it is around 60% and left side is around
40%. 60% is risk or 60% is reduced risk?
60% still risk for ejaculatory dysfunction.
No. The current modified template RPLND, nerve sparing, bilateral nerve sparing RPLND, the risk of ejaculatory dysfunction is reduced to less than 5% or even 4%. Okay, that is why they do that. Okay, in classic, it is almost always it is drug ejaculation only. Okay, then
there is a template dissection that you do for this RPLND. What are the upper and the lateral borders of the template?
Yes.
Sajeevan, can we stop it?
Okay. Yeah.
Just 5 more
There's a couple of
For
questions.
five
and we
hours
can
in
put it.
rapid fire and finish.
Hey.
So Jay can ask some
Okay.
questions.
Teratoma in the RPLND. Why is it necessary to remove it? What can it transform into or secondary malignancies that can occur?
Growing syndrome. Teratoma growing syndrome.
Growing
Like it can
teratoma syndrome.
growing teratoma syndrome.
What can it transform into? Or which is the most common transformation that the teratoma can undergo?
It can.
There is one carcinoma and there is one sarcoma. Okay, read that. There is an
Okay.
adenocarcinoma, GI adenocarcinomas, and then rhabdomyosarcoma.
Okay.
Okay. Cryptorchidism, how does it affect the risk?
Cryptorchidism, it is associated with 4 to 6-fold increase in testicular malignancy.
And if the testis has not been, like the patient has not undergone an orchiopexy, till what age will that risk be high?
Previous studies have shown before, if orchidopexy was done before puberty, there was 2 to 3-fold decrease. But now studies have found that even after, if orchidopexy was done after puberty also, the risk remains the same, about 2 to 3-fold.
But would you prefer to do that even then, if the patient has not undergone it before puberty?
Yes, sir.
Why?
Still there is reduction in risk.
No, the risk does not reduce. I say that the risk does not reduce, but I would suggest the patient to undergo orchidopexy. Why? The testis has now become visible, right? You will be able to detect the lung.
Okay, you can do early detection. You can do surveillance. You can palpate. You can do ultrasound. You can keep this patient in active surveillance mode, active early detection mode. Okay, that is the reason. Okay.
Let's say the patient has undergone a scrotal orchidectomy and the germ cell tumor has been diagnosed. You have treated the patient with whatever therapies you have done. What do you do for the scar of the scrotum? Is there anything you have to do for that?
Hemiscrotectomy or radiation to the hemiscrotum.
Is it really necessary?
Chemotherapy, since we are giving chemotherapy, it should address.
Yes, generally the chemotherapy itself should address. There is no need. Earlier, patients used to, the surgeons used to do a scar revision. Nowadays, it's not necessary. Okay.
Okay, I think we can finish Len.
One last question. And an opposite testis biopsy while doing orchidectomy. In which situations would you do? Testicular sparing surgery. Yeah.
Usually, if there is a tumor, if there is only solitary testis present and it is and tumor is limited to that. If tumor is present in a solitary testis, or if bilateral testis are crypto are higher.
If there is an indeterminate
atrophic bilateral testes are atrophic, or if the size of the tumor is less than 3 centimeter, testis sparing surgery.
There is a volume that determines out of the total testicular volume. If the tumor volume is not more than 30%, and
synchronous bilateral.
Yeah, synchronous metachronous tumors you can consider. And also in very indeterminate lesions on the ultrasound, if you're not sure and the opposite testis is normal, then you can do this testicular sparing surgery. But provided you have a frozen available with you. When do you do an opposite testicular biopsy while doing orchidectomy? 2 or 3 situations where you would do that.
If patient has intratubular germ cell neoplasm in the opposite testis, biopsy is required.
You don't know if there is a GCNS in the opposite testis.
If the patient has some atrophic testis history of cryptorchidism,
Cryptorchidism, atrophy where the volume is less than 12 ml, one more. If the age is less than 40.
40 years.
Okay. That's all from my side, I guess. Anju has really answered well. Although your history physical examination should be a bit more better. I guess from the points that we have raised, you have noted down those. Right?
Testicular germ cell tumor is a common topic for exam. So in and out, all those things you'll have to learn. So most of the time, the things will be stuck with the basics itself. So read about the basics, read DVITA, everything is written in there. Almost all points are there in the DVITA itself. Okay. So I think we can stop there.
Yeah.
Okay. Okay. Thank you all. Thank you for participation. And all the best for your exams.
Thank you, sir.
Thank you, participants. Thank you, Ampok, Boban, and Arun. Over to you.
Yeah, we had a very good discussion today, sir. I mean, germ cell tumors, we all know that definitely there's a very high probability that you can get it as a case. And there are so many things can be asked. So we should know about testicular tumors or germ cell tumors in and out. We had a very good discussion. And I think most of the questions were answered. And all the postgraduates who attended will definitely benefit from this discussion. So thank you. And we'll come back next month with a different topic. So thank you, Sajeevan, and thank you, Sujay, for an excellent case discussion. Thank you.
Thank you.
Bye, Sajid.
Bye. Bye, sir. Thanks.
Okay.
Good night, everyone.
Good night.